Thank you very much for asking me to speak today. I have one small conflict of interest, although I wouldn't call it a conflict of interest, I'd call it an interest. I'm a trustee of a charity called Birthrights, which works for human rights in childbirth. So that's the skin I have in this game, in the maternity game. And I'm taking the talk I was given quite literally. How do I do what I do in obstetric anaesthesia? So Ramani spoke to us earlier on about the importance of context. So I'm going to lay out to you the context of where I do what I do, because I think it's very important to explain the rest of it. I work in a moderately sized maternity unit in southwest London. We do 5,000 deliveries a year, and our obstetric lead has asked that we're capped at that. So he feels that's the safe amount of deliveries for us to use. He's made himself extremely unpopular with hospital management and CCGs alike because he's refusing to take anyone else, but he's kind of a hero in our eyes. So we do about 5,000 deliveries a year. We have a fetal medicine unit and a maternal medicine unit. So we get mothers and babies who have complex needs, and those are both neonatal needs around prematurity and other diseases, and pediatrics, or neonatal surgery, I should say. We have a standalone obstetric anaesthetist on call, and that's me, and we have resident obstetrician consultants overnight, and they're sleeves up, working hard overnight, so they're not sleeping in their bed while this work gets done by someone else. They're very much on the front foot. And this works well for us. So we have a very low hypoxic encephalopathy rate. We have a low number of babies that are born with low APGAR scores, if that double negative is positive. And we've done this in a kind of holy grail kind of way because we also have a very low intervention rate. So we have a lower than average number of emergency cesarean sections, certainly for a hospital of our size, and I think definitely for the complexity of the patients that come through. But we also have some really patient-centered outcomes. So we have high skin-to-skin rates, high breastfeeding rates. For what it's worth, this approach is quite popular with the CQC. We were a little island of green in the rather large red report that St George's received last year from the CQC. They were very pleased with how we do things, and we've won a number of awards for the teamwork that goes on in the trust. So that's the context of the kind of unit that I'm working in. It's a nice place to work. Initially, I thought I was a little bit of a square peg in a round hole at this conference, but I was thinking, really, maternity is the real perioperative medicine specialty. So obstetric anaesthetists and obstetricians deal with perioperative medicine all the time. And this is a photograph of our board in the middle of last week when I was thinking about what I was going to write on this presentation. And there's a few things there I think it'd be quite helpful just to highlight. This is our patients with maternal or social comorbidities. So we have a lady here who's got lymphoma. We've got another lady who's got two ladies with sickle cell disease. We've got TB. We've got pancreatitis. And of course, we've got type 2 diabetes and we've got obesity. So that is a big part of our workload on the labour ward, is actually dealing with these women that have other comorbidities in their lives that are going to influence their delivery. And it's worth noting at this point that the Embrace report now shows that 2/3 of our deaths are attributable to things not unique to the labour period. It's attributable to other maternal physical health or maternal mental health. We have some women, although not so many on this board, so that was maybe a good day, that we're dealing with the impact of previous pregnancies. And that may be the physical impact, so scars, morbidly adherent placentas, and more often now, psychological impacts of what's gone on in previous pregnancies. So a very difficult delivery makes it very difficult for a woman to come in subsequently and have her second baby. So that is an increasing part of our workload. Sepsis is a big thing for us, as I guess it is everywhere in the hospital. Not too many with sepsis there that day. I think we were quite lucky. And another big part of our care is the multidisciplinary nature of looking after two patients. Now, of course, the mother has primacy in law and is our first concern, but we're delivering quite a lot of complex babies, really. And there's a huge amount of collaboration and cooperation that needs to go on to make that happen. So we do some fetoscopic surgery. We occasionally do a procedure, a neonatal surgical procedure, before the baby's been detached from the umbilical cord. That's a fun day. There's not a room big enough for the number of people that have to come into the theatre when that happens. But we have a lot of complexity around discussing with obstetricians, with neonates, with surgeons, with paediatricians about the best time and the best way to deliver sick neonates. My last point here is, I've just circled up the top there whether you can read about eating and drinking. In maternity, we love a bit of dreaming. We like drinking, eating, and mobilising. All our elective caesarean sections bring in a sandwich to eat in the recovery room when they're finished. And we're really encouraging drinking isotonic solutions in labour. There has been some interest recently in hyponatremia when women drink to thirst when they're in labour, and I believe that's likely to be a subject of one of the UCOS studies, so a national surveillance study. So perhaps drinking freely in labour water is a watch this space, but certainly we would encourage all our women, regardless of their risk category and regardless of whether they have an epidural or not, to drink isotonic drinks in labour. So how we conduct things in the labour ward to make it work? We do twice daily ward rounds with our obstetricians. We see a lot of patients that wouldn't necessarily fall into the need to see an anaesthetist camp, but I think we do that because we all work together and we see these patients together, so if anything does crop up, we've got a good sense of teamwork between us. We have a maternity HDU, which has up to level 2 care, and that's all those patients under joint care of us, the obstetrician of the day, and the maternal medicine consultants who take a special interest there. We use electronic fetal monitoring. We measure the ST segments of all of our babies via a scalp electrode, and that gives us some extra advice and really some extra reassurance to know whether these babies need delivering or not. And all of this is electronically analysed, giving the midwife really a third pair of eyes, the midwife, the obstetrician, and the electronic triggering system to see whether babies are okay during labour. The anaesthetists all attend the CTG teaching that the midwives and the obstetric registrars attend because we feel it's an important part of this perioperative care that we understand this as much as they do. So that's a little skill I've learned. And this, I should say, these forest plots at the bottom show there's some benefit of this approach versus the traditional approach. And we defiantly don't follow the NICE guidelines on that. We have multidisciplinary training sessions. We use the prompt course, which some of you may be familiar with, which is the standard course. But we also do some just-in-time training. The nice thing about maternity is you know a patient's coming. You know they've got a due date. If they've got some complexity in their history, you can practice your simulation scenarios just before they're due to deliver. So we did have an obstetrician in a what's the most PC way to say this, in a sumo suit, practicing collapsing in one of the rooms just before we were expecting a super morbidly obese patient to come in. And we had practiced that just before the patient came in, so we were really ready if anything went wrong with that patient, which thankfully it didn't. We also run some in-situ focused training events, so sepsis, and most recently on AKI, multidisciplinary events where we take over a few rooms. We have some practical exercises for midwives, junior doctors, and everyone to do together to learn about topics of note, so around sepsis, AKI, been important for us recently. But on to the anaesthesia. This is a photo I've taken from social media. I think this is the criticism of obstetric anaesthesia, and I do understand that we are a choice of a big needle or a little needle, and the dose is either 3.5 or 2.5 or 2.3. I find it fairly tiresome, and you're not going to get very much of that from me, I'm afraid, because I don't think that's where our expertise lies. And I hope I'll show you I don't think our patient outcomes to rely on that either. But if we must talk about big needles and little needles, I'm going to talk a little bit about analgesia. This paper, before we go too deeply into doses and techniques, this is a very important systematic review that looked at over 150 different studies looking at the management of pain and maternal satisfaction. And it showed that actually women don't really care about pain particularly. The four most important topics that came out of this systematic review were that women had the correct expectations before they come in, they get good staff support, they have a relationship with staff, which means that those staff members are present and listening to them properly, and that they have some involvement in the decision-making that happens around labour ward. What wasn't important in this systematic review was whether the patient had pain or not, whether they had medical interventions or not, whether they were immobile or not. We worry a lot about motor block, don't we? The physical environment or the demographics of the patients. So everything else I say should be understood in the context that this is really the most important thing, is to actually involve patients in your decision-making and to have a good relationship with them. This is the evidence base for how we should be practicing in maternity. But onto the needles, we must head towards the needles. If you were going to look to maximise your effectiveness in labour ward, there's a few things you can do to make life easier for yourself. A bolus technique is better than a continuous infusion, and I think actually most of us should really be doing this now. It's the subject of a Cochrane review. It's fairly old news, both through animal models and in real life, showing that you get better spread if you use a bolus technique. You get much higher maternal satisfaction with a bolus technique as well. Just how those boluses are delivered is a little bit more of a topic of debate. So in my unit, we still use a midwifery-delivered bolus. So the woman asks for some pain relief and the midwife hopefully gives it to her. There is some evidence of increased efficacy for a patient-controlled method, so they have less motor block and more patient satisfaction if the patient controls that infusion themselves. But more recently, there's been some smaller studies looking at a programmed intermittent dose. So that is a machine that's programmed to give a dose at a regular interval, in addition to what women can press a button to get the dose as a traditional PCEA program. And there's some suggestions these are superior to PCEAs. There's small studies, only 100 patients or so, show that they have some better pain scores and better motor function than the traditional PCEA. But because this is a new area, there's a lot of debate about the correct dosing interval, the correct dose given, the correct dilution of the dose. So there's quite a lot of heterogeneity at the moment. But I think that once those kind of dosing questions are answered in studies over time, we'll get to a point that we'll have a more personalized demand and a managed bolus technique that maybe changes through the course of labor, changes based on mother's feedback, that's much more personalized to the individual, and it's not a 20 mils every hour suits all. Something else you could do to improve your labour analgesia technique, and this has certainly been the topic of a lot of debate and quite a few column inches in journals, is a newer technique called a dural puncture epidural. So you may think of it as a forgetful spinal epidural, where you put your epidural in and then make a puncture in the dura, either with a 25 or a 26 gauge spinal needle. 27 doesn't work. And the theory is that over a period of time, you get some of the benefits of a spinal anesthetic because drug passes more easily through the hole that you've made, but you don't get some of the side effects of the spinal component of a combined spinal epidural. And this has been tested in a randomized control trial. It is small, so 120 patients to the 3 techniques, so only 40 in each group, looking at primary outcomes, which was a better pain score and maternal satisfaction and the side effects of the 3 different techniques. What they found that the dural puncture epidural was slower onset than a CSE, which you can kind of understand, but it's quicker than an epidural. But the dural puncture epidural had a greater sacral block than a pure epidural did, and it had fewer side effects, so less hypotension, less itch, and less requirement for a doctor's top-up than either epidurals or combined spinal epidurals. It was commented, and I think that's correct, that this sample is too small to assess whether it's a particularly safe technique or not. But I think it's a technique that I would use if someone was further on in their labour, so sacral pain was more of a problem with them, but I did want them to maintain a little bit more motor block for the delivery that is to come, and I felt maybe a CSE would impact on their motor function a bit too much. So maybe there's a place for a dural puncture epidural or a forgetful CSE in our armamentarium late in labour. Anaesthesia for theatres, there's nothing new really to say about how we manage these patients. This is a consensus guideline in a very good journal that came out earlier in the year. And I think the 2 things to note is that it's prophylactic vasopressors that they recommend and a crystalloid colloid. They also say colloid, so I don't know if that's literally the only guideline that's got colloid left in it, not in a negative way. So that is the best way to avoid hypotension, and that should be alpha infusion of some sort, usually phenylephrine with us, and something with some beta action as bolus if you need it on top, so that's usually ephedrine, isn't it? In terms of pain relief afterwards, there's been a lot of interest over the years with TAP, and I think what we've come down to now is if you have intrathecal opiates, if you have some diamorphine or some morphine if you're not UK-based in your spinal, that a TAP block will give you no additional benefit. If you have a general anaesthetic for your cesarean section, so you've got no intrathecal opioids, then a TAP block may be of benefit to you. There are some quite alarming studies that show serum levels of local anaesthetic get really quite high after post-cesarean section TAP blocks, because presumably a little bit of different protein binding, and there's a different protein profile in the blood in pregnant women and women who've until recently been pregnant. So that's something to be wary of, and I think the latest guidelines would say that you err on the low dose if you're doing a TAP block for a woman post-cesarean section. What you could consider as well is the addition of clonidine to your spinal. That has shown in this systematic review and the meta-analysis to reduce the requirement for opiates in the post-operative phase, with the understandable side effect of increased sedation. So it perhaps might reduce the amount that this lady can mobilize, but it will improve her pain scores. So I think clonidine is very much in the personal preference area at the moment rather than anything that's widely adopted. In terms of general anaesthesia, we follow the Difficult Airway Society guidelines, which are great. We have two little addendums to that. We use Thrive, which is this high-flow nasal oxygen. The hospital has done a number of trials on this in other areas of the hospital, so the equipment is simply local. But there is some evidence in the non-obstetric group that this will increase your time to desaturation, and the rise in CO2 that you see is not felt to be significant for the fetus. So we would advocate using Thrive as part of a general anaesthetic. And we also encourage everyone to have an early use of video laryngoscope. So some of us would even use a video laryngoscope as their first line. And that's come from this Cochrane review, which shows the first use of video laryngoscope in potentially difficult airways, which maternity airways are, would be beneficial to you. The human factors is a big part of what we do in theatres. We drill this regularly. And I think the most important part of the difficult airway guidelines is that what you do if you don't get the tube down. And if you don't have a good relationship with your obstetrician, that is a very awkward conversation. So that's why we drill it. We use this shadow board to call and response, practice what we need to say and what we need to discuss before general anaesthetic, and to make sure we have all the equipment to hand. As some of you may know, the DREAMY study is ongoing, looking at prospective look at awareness in obstetric GAs, which we're recruiting patients for. But we've actually moved away from thiopentone and onto propofol, which I think a lot of maternity units have for this. And on the subject of theatre births, I just wanted to show you the Each Baby Counts report. So this is like an embrace report, but for babies, I guess. So looking at severe encephalopathy and stillbirths. And they emphasise for us as an anaesthetic group to think about the human factors involved and to think about situational awareness. So there were no directly attributable anaesthetic fetal deaths or stillbirths, but there was a kind of multifactorial impact of delay, which anaesthesia is sometimes responsible for because of that task fixation you have at the time of maybe one of these rapid sequence spinals or a rapid delivery in a theatre. So they advocate senior involvement early, and they advocate that local reviews must be multidisciplinary. So I'm sure very few of us are involved in the reviews of these deaths, but they're advocating that there's much more multidisciplinary involvement in looking at these incidents, which will include us. So lastly, just a little bit onto how we're doing, and this is where I think the importance of it lies. So there's a systematic review there up in the top corner from BMJ Open, which shows that there's a strong link between patients' experience of care and the clinical safety and effectiveness of the care they receive. And we believe this wholeheartedly in maternity, that patients know when they feel unsafe. And the maternity patient, you've got usually a young, well-motivated person. It's often their first time in healthcare. It's a really unique situation for you to gain some feedback from that patient. So we do individualised feedback of all our anaesthetic performance. And here's one of these word clouds of the kind of words women use to describe our care. We have a buddy system to reflect on any of the responses we have, if that's not what we were expecting. And as a part of that, we've drawn up some formal pathways for complications. So post-dural puncture headache and neurological things have a formal pathway. And we have a debrief clinic where women can come back afterwards and talk through their delivery if it was difficult or if it didn't go according to plan, just so they can get their head around it in case that next baby comes and they've still got some psychological impact of that. And then lastly, what we're doing furthermore on the patient experience side is a patient-based co-design process, which includes staff and patients talking together about how care should be improved, and then staff and patients working together on what that improvement of care will finally look like. And what's come out of those conversations is that our staff want to look at what makes them happy at work. They want to look at joy in work. Our patients want us to look at tasks that distract us from care. So when we've got our back to them and we're on the computer, that's something that really came up as a safety concern and an experience concern for them. And a little bit about changing the physical environment, changing how we talk to each other and how we talk to them to make care better. So we've had some initial sessions with patients. We're now going away and working on what they've asked us to work on, and we'll come together later in the year to check the pulse of that and to go again. So that's experience-based co-design in action, really. And that was all I was going to cover. Thank you very much.
Sorry, it was so brief.